Well, a warm welcome to everyone who's logged on this afternoon. Good afternoon to everybody. I'm John James, and this is now our third series on COVID-19 and sickle cell. We held two previous ones which were very successful. We had so many questions that we couldn't field all of them during the time that we had. And we've decided to hold the third one now, partly because lockdown has been lifted, children are going back to school, businesses are partially opening. So the circumstances for people who live with sickle cell continue to change. And at the same time, the virus hasn't gone away. So what we're hoping to do in the hour or so that we have this afternoon is to hear from some clinicians about what they're seeing in clinics, hear from one of our members about her experience of coming out of lockdown and shielding, and also hear about some University College London COVID-19 research that is going to take place. And then there'll be plenty time for questions and comments, particularly whether or not what people have heard is consistent with their experience, or whether people are experiencing other problems which they might need some help with, either from the society or signposted to other organisations who can help them. It's a pleasure also to welcome my colleagues who are on the panel this afternoon. So I'll just welcome them all, but they'll probably introduce themselves when they speak. But welcome Keisha Osmond-Joseph, who is a nurse specialist at Queen's, which has a big sickle population, adults and children. Welcome to Zainab Garba Sani, who is one of our member patients, and also Professor Kirkham from UCL, and Anna Hood about the research study. And also, last but certainly not least, Professor David Rees, one of our medical advisors, who's been on the previous two events, and Kofi Anie, our scientific advisor. So welcome to you both, right, we're ready to go. So without any further ado, I'm going to ask you, Keisha, to start off, and Matthew's got your slides, so you just tell him when to go.
Lovely. Okay, thank you. Thank you so much, John, for inviting me to join you guys on this call. So my name is Keisha. I'm the lead nurse for the hemoglobinopathy services at BHRUT. I wasn't quite sure which perspective you wanted me to talk on, so I just basically put together some slides regarding what we did, how we planned once we received information and changes had to be made. So I've got a couple of slides, and then people can ask me questions if they need to. Next slide, please. Okay, so we received some data, some information from the government and from the National Hemoglobinopathy Panel in March and April, just informing us of the changes that we would be recommended to make. So in the first instance, sickle cell disease, specifically homozygous sickle cell, was identified as a at-risk one of the conditions that was listed on the at-risk group for the government. And on top of that, the National Hemoglobinopathy Panel recommended that all of the conditions under the HBO banner, so all genotypes for sickle cell disease and thalassemia, be recognized as well. And so we had precautions that we needed to take. They gave us some advice on what we should be doing in regards to attendances to hospital, to our clinics, and advice on transfusions. So the first thing we did was to send a letter out to patients informing us of the advice that we received in regards to people shielding and taking immediate action in regards to that. We have a number of patients who are within the workforce, and a few of them actually work within the NHS. And so we quickly had to give them advice to then escalate up to their managers in regards to how best for them to be protected, and the advice was immediately to shield. In regards to medication and monitoring of things like hydroxycarbamide, the NHP suggested that we move our regular monitoring to 12 weekly. This was to try and reduce patients presenting into A&E, traveling onto the trains and the buses, etc. And so we put that also into the letter. And then our changes to clinics. So I've got a separate clinic slide and day unit slide as well. And then attendances to A&E. So what we made very clear in the letter to patients was that the advice obviously is to shield, but if they required emergency input, that they must come to A&E. It can't be a reason not to present, and we would do all that we can to shield and protect them once they presented to A&E, but they shouldn't delay presentation to A&E, and that was really, really important for them to understand. We on the letter gave them contact details for the service, for all the team members, names, email addresses, the best way people could contact us. And then, which I found was really useful, we sent a letter out via our CCGs to our GP colleagues, requesting them support in how we manage pain in the community. So there are a number of GPs who were or have been reluctant to prescribe things like, MST and stronger opioids in the community, just requesting their support in trying to minimize patient presentation and looking at their criteria for prescribing opioids, and asking them kindly if they could, once they triage patients over the phone, if they required anything stronger in that middle management part of the pain ladder, that they would be happy to prescribe codeine, and depending on their own assessment of the patient, and also requesting that they prescribe prescriptions, regular medication, over a 3-month period instead of 28 days where patient had to come back to the surgery for repeat prescriptions. Next slide, please. So for A&E presentations, as I said, it was business as usual. We encouraged the patients to come. Our BHIUT, we attempted to not physically configure A&E, but to have different sort of streams for patients to come in, screening patients as they presented to our front doors, looking at whether or not they had any criteria to be separated out of the pool coming into A&E. And that way identifying patients as much as possible. We'll be doing an audit looking at time to analgesia, which is part of our KPIs anyway, to see whether or not during the COVID period that was affected, but I presume it would have been. So from April to July, we had a significant decrease in presentation, and I think this was mainly obviously because of patients' anxiety coming into A&E. But it's what I wanted to note are patients who we had a small group of patients who present quite frequently. I think there might have been a dip for a month or so, but this didn't really deter frequent attendance from coming into A&E. What we tried to do over that period of time was to increase our telephone contact with our patients, especially our elderly or vulnerable patients who we knew live on their own, who had minimal support network, to touch base with them to ensure that they were doing well and there weren't any things that we needed to support them with. And if they did, then we would try and as much as possible to try and help out with those things. And again, the presentations resumed from July, and then after shielding was then sort of released or relaxed after the 3rd or the 1st of August, we saw presentations beginning to come back to normal. Next slide, please. So our day unit presentations, the day unit was affected mainly because our trust contingency plans in delivering cancer treatment. Our hematology oncology day unit is heavily cancer supported, and so we had lots of cancer treatments being cancelled, reconfigurations happening. Some of the workload had to be shipped off to private hospitals to ensure patient safety, and so for a period of time between April and July, we had no access to our sickle cell patients coming into the day unit for pain management of uncomplicated crisis. I'm happy to say that that's now resumed following additional screening process has been put in place. Patients are encouraged to come through the hematology oncology entrance and not the main entrance, where they have some screening done by members of staff in the reception area before they come through to the heme onc unit. And at the moment, there are further plans to continue screening, including COVID screening for patients coming in regularly for transfusions. Next slide, please. So automated red cell exchange transfusion, this was business as usual. I must say, in the mix of trying to looking at possible redeployment, it was a bit of a battle to argue my point to ensure that my staff remain in the service, because in a heavily oncology division, the trying to find staff to be redeployed to ITU and A&E and other areas of the hospital was really tough, and having automated red cell exchange continuing throughout the whole process was something that I really had to argue for and rationalize with. And once we managed to do that, then our service was not, I have to say, it wasn't broken at all. We continue to provide that service for our patients, and I'm really happy that I was able to keep our staff in place to keep that running. So again, we had some conversations and some information coming from our HCC, which is Barts Health, from NHS BT, and also the transfusion lab regarding considering reducing the number of units, and which we did. So we moved from, on average, our patients used between 6 to 8 units, and between April to July, we moved to a standard of 4 units for everyone. So many of our patients were, you could say, partially exchanged. But I'm happy to say that we've now resumed that, and patients are back to their usual amount that they normally have. During the period of April to July, we did about 59 automated red cell exchanges, and 8 of them emergencies. And I think one of the the great benefits of having assets in the trust is that we could manage these 8 emergencies, because, to be quite honest, they could have been suboptimally managed, and many of them may have ended up in ITU if we weren't able to offer the automated red cell exchange. So I'm happy that we were able to come in early, provide treatment early, and ensure these patients stay closer to the well end of the spectrum. Another thing to celebrate is that we now have 2 machines, and on certain particular days we run them concurrently, which I think is a great achievement for us. And the next battle will then be to try and train up other nurses within the division to do automated red cell exchange, because it's not something that's sustainable for 4 nurses to be running 2 machines. So that's another challenge coming forward for us. Next slide. So antenatal counselling and partner screening. So our service forms part of the antenatal screening pathway. This continued business as usual. We had advice from Public Health England to continue to provide screening for partners and counselling for couples who've been identified as being at risk. One of the changes for maternity was the self-referral was changed to an online booking system where women were able to book in quite early and start the process off early. We've done really well to continue partner screening, and to a point where we've increased screening for husbands during that period. Last year, I think we were averaging about 60%, and during this year, up until last month, we had increased our uptake by 91%, which is really good. However, it is to note that many of the men attended on their own, and I think the women, obviously with pregnancy, they were more at risk of contracting COVID, and so they mainly attended for the antenatal appointments. We had telephone consultations with them on the phone, and then they sent their partners in to have the blood test done. Next slide, please. Genetic counselling. So these are mainly our are GP referrals, incidental findings, people who've popped to their GP feeling lethargic, feeling unwell, and they've had a HBO screen done and found to be a carrier of something. This is mostly the referrals that we get into the genetic counselling. So as these clients, I should say, because they're not patients, they're found to be carriers of unusual hemoglobin, they were considered to be, at present, especially during COVID, less urgent. And so depending on the triage, if there was a couple outside of pregnancy that were at risk, then obviously we would bring their session forward and completed that session in person using all the screening guidelines. But we will now resume our genetic counselling clinics and now be re-accepting referrals. But the plan moving forward is to move these clinics to virtual clinics and using more online information and leaflets to talk through genetic counselling. Next slide, please. So community support, I'm sure you could imagine, was immediately stopped due to the risk to patients and staff in regards to COVID. So from April until now, we have not yet resumed community home visits. What we have done in place of that is doing some additional phone calls, as I mentioned, post-discharge and isolating our most vulnerable patients and ensuring that they have regular phone calls and catch-ups with them. So we're currently looking at our home visit offers and reviewing it, how best we can provide that service. So currently we're going to be looking at patients who have been admitted to hospital and post-discharge have had a negative screen within the last 48 hours, where our nurses can go in and follow them up at home. And then obviously we have to think about transportation and how we transport and dispose of our PPEs with visiting. So we're looking at how best to do that. Next slide, please. And then for our clinics, so yes, so following the government guidance and from the National Hemoglobinopathy Panel advice, we immediately moved our patients from our face-to-face clinic to telephone. All our appointments were converted to telephone clinics in March up until June. And actually, for the first few weeks, our CNSs completed these clinics with a lot of consultant support. Our consultants were requested to be part of the COVID rota, and so we actually did the consultant clinics with support from the consultants. So what we would do a few days before would be to go through the clinic lists to identify patients who nurses could have a nurse-led clinic with, and any patients who were deemed complicated or required a bit more advanced information and consultation, then we would leave those to the consultants to ring. But the nurses from between March and April did most of the consultant clinics. But from the 10th of June, we've moved to a new software, Attend Anywhere, providing video appointments, which is it's been working really well, actually. I think a lot of the patients have fed back finding it really useful. One, to be able to see the consultant instead of having a telephone consultation, but also feeling safer in their homes and not having to travel. So there's lots of benefits to it. But we also have 2 spaces where, if required, patients, because obviously with sickle cell, there's things that we need to examine. There's particular things that we need to see in person. We've got a couple of spaces on those clinics of face-to-face appointments. And I think that's me. I didn't know if there was anything else anyone else wanted to find out or ask me, but that's kind of where we're at the moment with HBO at BHRUT.
I'm conscious of the time, so there will be plenty time for questions at the end, and I know you might not be able to stay till the end. So, but well done. And let's move straight on to Zainab and tell us, because you've been living with the condition, you're being shielded, you're now not shielded. So tell us your experience, and I'm sure when we get to questions, some of that will resonate with other patients or family members. So over to you, Zainab.
Thank you, John. I've got a couple of slides, but there's not much writing in them. They're just pictures, so you don't have to just see my face for the next 10 minutes. So I'll start off just saying a little bit about me. So can we have the next slide, please, Matt? Thank you. So a little bit about me. So I have my genotype is HBSS, so I have sickle cell anemia, and I've known this all my life. So I was diagnosed when I was a baby. Normally I am fit and well, so thankfully normally I probably have around one attendance hospital admission per year, and the rest of the time thankfully I'm quite fit and yeah, quite well. I live quite a busy life, so in addition to like work, I do quite a lot of volunteering. I have a quite busy social life, so I'm quite a people's person, so I love seeing people. So you can imagine what the last couple of months have been for me, not being able to see people. That's been quite difficult. And I work with NHS England and NHS Improvement. And then for those of you who don't know of that organisation, basically it's the organisation that helps lead the strategy and the policy for the NHS in England. Next slide, please. So before shielding, I'll kind of take you through like the process. So I'll tell you what it was like just before shielding, then during shielding, and then after shielding, and then just I'll finish on some reflections. So before shielding, I was continuing living my busy life. I went to see the football at Arsenal just a couple of weeks before everything stopped. And you can imagine how many people were there. I was commuting still in London. I had recently come back from Saudi Arabia, where I had that was on a religious trip, and there was people from all over the world there. So I was in contact with quite a lot of people up until maybe the end of February to the start of March. And then I got word that there's probably going to be a shielding letter, and sickle cell was probably going to be on it because obviously I work in that organisation. So I started thinking, okay, then, so what do I need to start preparing myself for this? I live on my own in London, so I had to start thinking about whether I stayed alone in London or did I go back home to be with my family who live in Birmingham. I think there was ups and downs I was trying to weigh up the pros and cons, and the pros being that if I had gone home, I will have, thankfully, I've got some space, my own space, I have some gardens, so even if I don't have to just always be indoors, I can go outside. God forbid I got ill, I was able to have that support and that, and people always, there's going to be people around me. People could actually help me with my food shop, because actually for the first couple of weeks, the first couple of days, sorry, just before lockdown, I went to the shops multiple times, and even paracetamol, I just couldn't get my hands on paracetamol. And for the first time in my life, I had to ask my haematologist, can you please prescribe me paracetamol, because there's just none of them. All the shops, everyone remembers, all the shop shelves were completely empty. So it was one of those things that I had to think about, what's the likelihood of me being able to go through shielding 3 months completely on my own. I couldn't even get a delivery slot, so you can just imagine how difficult that was. There was also some questions that I had around hydroxycarbamide. So I've been on that for at least 5 years now, and as you know, hydroxycarbamide is one of those drugs that you have to keep monitoring people on it because of the impact it has on your neutrophils, and obviously that means you might be more susceptible to infections if you have low neutrophils. So for me, it was like, oh, should I still be on this drug? Because this drug has been an absolute miracle drug for me. It's helped me stay well, it's helped me keep out of hospital. However, if this means that I'm going to be more vulnerable to COVID, should I be stopping it? So that was a conversation that I had with one of my specialist nurses, who told me no, keep on it, because that's the best thing to do. So you can imagine all of these questions, and there was so much uncertainty at the time. And one of the biggest questions I had as well is, if I went into hospital and I did get COVID, would that mean I'm not a priority? So would they prioritise other patients over me because I have sickle cell, so I'm less likely to survive? So you can imagine it was quite a scary place to be at that point. Next slide, please. So the decision that I made was to go home. So I shielded back home in Birmingham. So like I said, I at least had some outdoor space, which is nice. I wasn't cooped indoors for 3 months, which was good. And at home, because all of my organisation were mainly the majority of them were working from home, it was okay. I didn't feel too out of it, and I didn't feel like I was missing out on too much. However, what was really difficult for me was feeling a bit helpless. We were clapping every Thursday night for these amazing people working on the front line, and I had friends who were also working, helping set up the new Nightingale Hospital or in London Ambulance Service, actually volunteering their time, and I wanted to do that as well. I felt really helpless being stuck at home and looking at spreadsheets and all that kind of stuff, and I was like, well, is this making a real difference and an impact? That was quite difficult. I also had to, because I was working at home, I had to try and think about the boundaries I was drawing. So because someone said to me the other day, which I thought was quite interesting, we're not working from home, we're living at work, and actually we're in the same space. I set up my workspace in my bedroom, so actually I was always in those 4 walls really, and wasn't getting out, and the emotional toll that can take as well is quite a lot. Also, just because I was hearing all about COVID, I was actually working on the COVID-19 response right at the start of the pandemic, and then we were watching the news and everyone was talking about COVID, and even when your friends called you up, they just wanted to talk about COVID, so everything was just about COVID. And again, it just meant that by the end of the time, and by the end of the first month or 2, I was just my brain was fried, I was emotionally exhausted. And then just to point out around like how it impacted my health, I guess, during shielding. So because I am registered in London and I live in London, my GP's in London and my specialist care normally takes place in London, all the letters and all the communications around COVID went to my London address, whereas I was actually in Birmingham. So there was letters that I was getting that I actually didn't ever see. There was, if a hospital said that I should go to an appointment, I wouldn't know about that appointment. So it was quite difficult. I tried my best before I left London to try and call up the hospitals and say, can you please call me if anything changes or you've got any communications, because I will not see them otherwise. I tried to update my addresses, but you can imagine how difficult this was. So there was a lot of communications that unfortunately just didn't reach me. I'm quite lucky because, well, it's not lucky, but my brother also has sickle cell anemia, so he got a lot of the communications. So actually, I was able to keep up to date with what the advice was and the guidance during that time. I was also really lucky that I had Birmingham Hospital, so the City Hospital, and those haematologists, so they knew me before I moved to university and they knew me before I moved to London, so they were able to look after my care a little bit. The day that I had a health scare with my eyes, and I was able to call up the hospital, and they were able to say to me, no, we would recommend you to go in, even though you're scared, please do go in. And that was difficult for me. For the first time that I left home and I went and I was seeing everyone around, it was scary. It was scary to think that I was putting myself at risk, but then by not going into hospital and not presenting, I could have been putting myself at a greater risk. So it was just important to have that reassurance from healthcare professionals who knew what they were doing and had that support. The last thing I'll say whilst doing shielding was about getting my medications as well. So I could imagine, I was really lucky that I had Birmingham Haematology department who knew me and were willing to take on my care, so they were able to prescribe a lot of the medication for me, because even when my medication was prescribed in London, again, there was no way that I could pick it up because I wasn't there. And so yeah, there was just quite a lot to juggle between that. But next slide, please. So after shielding, so I guess because I had to go into hospital a couple of times during the end of shielding, I gradually started to get a little bit more used to it. So it was a gradual transition out of shielding for me, which I think was really helpful, because I think if I had just automatically suddenly come out of shielding. I think that would have been really scary and a huge adjustment. The first couple of weeks I was mainly only going out for walks with my sister, which was quite nice, and just I felt that it was one of those things where I hadn't been doing as much exercise as I wanted to, and the first day I went out for a walk, my muscles were shaking by the time I came home, which was crazy. And it told me, oh, Zainab, what have you been doing for the last couple of months? But you can imagine just working in front of a computer all day, working from home, that's not very healthy either. So yes, I really enjoyed that. And then I recently came back to London, and it's been a huge difference coming back to London, because it feels that there's this false sense of security here in London, and people are just going about their normal days like nothing's happened. And I walked through Soho the other day, walking towards Chinatown, and it was literally trying to like dodge bullets everywhere because of just so many people coming left, right and centre. And I guess for me, I'm having to constantly remind myself that even though it looks normal, it feels normal, remind yourself that it's still a real threat. And that's something that I'm having to consciously do. But I've been quite impressed with how hospitality and the restaurants have kind of adjusted, and it's been quite nice to just catch up with friends one-on-one and just to be able to see people in 3D rather than this two-dimensional virtual world. And I guess since I've come out of shielding, I've also got a better work-life balance now, because I've got actual things to do in the evenings rather than just also sitting at home. I'm able to stop at a certain time and say that, okay, that's enough work for today, let me we could do the rest tomorrow. So yes, that's how my last couple of weeks have gone. And can I please have the last slide? And just some 3 key reflections. So it's something they teach you in NHS is the rule of 3. So if you ever want to summarise something, say it in 3 things. So my first one is about just to recognise the impact of shielding on your mental health. And I think if I hadn't gone home, it would have been much worse. And for me to be completely alone for a long period of time, so for about 3 months. Also, even though I was with other people around myself, and at least around other people in the same house, and also I had my friends constantly talking to me, it still feels a bit lonely because you're just exhausted by all the phone calls, and it's just another phone call when you really wanted to see people. So it's just something to start thinking about as we don't know what's going to happen, if there's going to be a second wave, if there's going to be shielding again, but just to make sure that we are recognising that shielding does have a huge impact on someone's mental health, and just how I told you about how I felt before I started shielding and the anxiety that a lot of the uncertainty causes. The second thing is just about how coordinated care is really significant, and the fact that I had coordinated care from my Birmingham team, and they were able to coordinate with my London team and share results and have conversations and help me with get my prescriptions. All that was really helpful for me, and it made my life much easier. And I don't think I would have. I think it would have been another burden for me and another barrier if it hadn't been the case. And then finally, just the importance of information. So right at the start, we didn't know, like the questions I had around hydroxycarbamide, whether to still take it or whether not to. I can imagine a lot of other people had questions like this. So it was really helpful to be able to go to places such as the Sickle Cell Society's websites and see the information they gave, speak to healthcare professionals, and actually it was able to reduce my anxiety anyway. So it helps you keep well, keep positive, and manage your condition. So I'll stop there, but yeah, thank you. And if anyone's got any questions, more than happy to take them.
Thanks a lot, Zainab. That's, by the way, I like the infographics, so pictures are nice. So thank you for that, and just struck by the feeling of helplessness and the impact on mental health and the full sense of its security. So thank you for that. There will be opportunity for people to ask questions, but just so I can give them plenty of opportunity to ask questions, let's move to, I think it's Anna who's going to present. I know Fenella's around, so over to you, Anna, and then after that we'll open it up for questions and discussions.
That's good, thank you. First slide, please, Matthew. All right, thank you for the invitation to come and speak today. I'm going to be representing the lab today, but Dr. Kirkham is here, and so is Sadi Sahota, and we can all answer questions if anybody's interested at the end. So my name is Anna Hood. I am a research fellow at UCL, also a clinical psychologist, also from Birmingham, Zainab, so shout out to Birmingham. And I'm going to be talking to you today a little bit about one of our new studies. Our lab has worked for many years, and our experience has primarily been working with the sickle cell community and working on studies that hopefully benefit and help in quality of life for patients with SCD. This is a study in which we are recruiting individuals from all groups, but I will talk to you about one of the sort of driving aims of this particular research called Attitudes About COVID-19 and Health. From now on, I'll be talking about it as attached. Next slide, please. So as you saw from Zainab's wonderful talk just now, our lives have changed. Everybody's lives have changed in some way, be it big or small. And so one of the things that we were really thinking about when we were driving this study is thinking about how to capture these changes, both capture them in the moment, so what's happening right now, and over time. So how can we think about these critical changes that are happening in individuals' lives? Next slide, please. And so just a little diagram of what we were thinking about when we were developing the ATTACH study. So obviously there's COVID-19, the pandemic, and we've got all of these strategies that we've all now know so well to be able to put into place. So social distancing, hand washing, and much more recently, face masks. And obviously we all have an attitude or a thought about that. It's definitely changed our behavior. And we all have beliefs about, whether or not things are working, how they, are we able to do the things that we're being asked to do? All of these things can have an effect on our mental health. And really in relation to how, anxiety, worry, and social isolation. We're conducting this meeting, we're all in our own homes, whereas likely if this was not occurring, we'd all would be together. And that affects our overall quality of life. And so really that's sort of the idea around the ATTACH study, sort of how can we think about these elements and then think about how we can understand the mental health impacts a little bit better. And then, at the to drive that later is thinking about how we can develop interventions. Next slide, please. So, there are people who are being more affected. The SCD community being one of them, having to shield key workers, those who are older, members of the Black and Asian communities. We're seeing these systematic effects on these populations. And one of the concerns we had really when looking at some of these other studies, which so many of you may have seen or maybe even part of, is that are these voices being heard as part of these studies? And so that's one of the reasons we developed the ATTACH study. Next slide, please. And so, we know there are these daily pressures. We know there are other studies. We know, it's difficult to, maneuver and manage sort of lots of balls in the air as we juggle in our daily lives. So one of the things I'll talk about to you is what we hope is the ease of the ATTACH study to be able to be involved in it and be involved in it over time. Next slide, please. So the things we really want to be able to do, and the thing I want you to take away from what I'm going to say today, is we want to make sure that your voice is heard. And so elements of the ATTACH study, having obviously talking and coming here and talking to stakeholders and patients who this is affecting. We're getting feedback from communities, as you'll see in terms of our questions that we're going to be asking. So those questions are dynamic and can change and can reflect your experience. And we just want to make sure there are enough of these communities in your community involved in a study like this, so that when we bring this to policymakers or for change, we're really representing your groups. Next slide, please. So why participate in a study like this? So again, we want you to share your opinion. Let us know what's happening. As I said, to help inform future policy, to really think about what we can do next as we see, we saw some major changes that are going to be coming next week. And as we know, over the winter, we just don't know what's going to happen yet. Really contribute to our understanding of the mental health effects. I think Zainab did a beautiful job explaining some of those details. And we really, are considering, those mental health effects likely because some individuals are having to socially isolate or be alone much more often than might have and are seeming to have an effect that's disproportionate on some groups. And then the other thing is so that your responses can have a real-time insight into the effects. And one of the things I'll show you is the way we're trying to show the results or disseminate the results is in, you'll see those each day. And we're also trying to provide some compensation. So those who complete the monthly survey will go into a prize draw to receive a £10 Amazon gift card. Next slide, please. So how to participate? So it's reasonably easy, hopefully. So this is, we've partnered with an app developer. So one of the things, around COVID, everything has been so fast. So luckily there was a polling app that wanted to partner with our study and was very interested in these effects. It's called the Air My Opinion app. It's in the App Store. It's in on Google Play. So you could either, you scan the QR code. If anybody wanted to scan right now, they could do. It really is just go on to and download the Air My Opinion app. And then you would select the attached study. That's the only study there right now. So you'd be able to see us right away. Next slide, please. On that, after you've completed the consent, if you choose to be part of the study, these are the pieces of information that you'd be asked for on the app. We wanted to make sure that this is non-identifiable data and is also anonymous. So we ask your gender, we ask only your age range, and we ask you to provide your postcode so we can use the first four digits so we can see if individuals in Birmingham, for example, in London, are experiencing the effects differently. Next slide, please. Each day, if you choose to be part of the study, you'd be asked a very short question. This is a question, and I'll show you some results from this in a moment, that we ask. The questions, you're notified at 10 and 2, and it just comes as a notification. If you miss the question, it doesn't matter. The question's there for 24 hours, but after that, you just see your next day's question. So this particular question, so how have you felt? Have you felt the COVID-19 pandemic could bring people together or tear them apart? Is a question that we've been asking over time to see people's responses. Next slide, please. We're also asking to do a very short survey once a month. That button is within the app. So you just click on the button after you've completed your daily poll question, and you're taken to a server within UCL, where we ask some questions related to mental health, related to behavior, related to physical health. Are you shielding? Are you able to go to the appointments that you need to do? Are you able to be a parent the way you want to be? And we're also asking around stigmatization. How are you feeling, that you're being treated right now? And so we just ask if you could complete that each month. Next slide, please. Who can participate? Well, we're obviously targeting and trying to get communities who are not normally involved in this type of research, so their voices are heard. So it's like the sickle cell community, but we are asking you to share this with your family, friends. It's so that we can have enough people in this to be able to really drive change. And so you only have to live in the UK, a very broad age range, so almost anybody, and then just have an access to a phone where you're able to download the app. Next slide, please. And as I said, you can immediately see results. And so if you click on the see poll results, that's within the app. You can also see those on our social media. And then we're going to be feeding back to our partners like the Sickle Cell Society so that they can see the results as well. So you can see what other people are thinking as well, and if it's in line with what you're experiencing. Next slide, please. Okay, and that's all. So this is the attached study team. As I said, I'm Anna Hood, and Fenella, Kirkham and Sadi Sahota are also on the call. And Laurie, Hannah, Melanie and Jenny are also part of our team. I think I have one more slide. Yeah, and these are the things to be able to contact us. As I said, you just have to download the app, but we also have our lab website where you can find out more information and also download the app, and if you have any questions, or you can follow us on Twitter. Thank you so much.
Thank you, Anna. That's very comprehensive. Also, like the pictures. So obviously, you and Zainab, it's a Birmingham thing, I guess, West Midlands thing. But thank you very much for that. And obviously, the Sickle Cell Society has an important role to play for this important study in helping you recruit to it, so that in the future groups such as people with sickle cell can have their voices heard. So thank you for that presentation, and thank you to your colleagues who have logged on this afternoon. Right, that takes us to all the presentations. We've covered COVID. We're out of lockdown, but in contrast, the R rate is going up. So this is an opportunity for questions. What I suggest, I know we've got about 15 minutes or so. It would be helpful if people have questions or comments to either put them in the chat box or raise your hand, and between Matthew and I will manage that and point them to the right person to answer. And I can say to my panel members, if you've got questions, feel welcome to ask them as well. Don't feel excluded. So somebody's raised their hand. I don't know who that is, Matthew, but let's have that question.
So I had a question really for Anna about her study was about access for people who don't have, access to IT. And that's one of the things that has emerged in COVID, is that actually everyone always says, oh, everyone's got a phone, but it's not true. And in fact, quite a big proportion of children that we see, haven't had access to IT and have missed out on schooling. And that is, again, disproportionately affects the sickle cell population. So given that you want to target people whose voices aren't normally heard, do you have any way of targeting people who can't afford mobile phones with access to the internet?
So you don't need access to the internet to be able to do the daily polls. So you would just need, because it's an SMS message. So as long as you do have the ability to be able to send a text message, you can be involved in the daily polls. The other thing I would say is that to be able to do the survey, one of the things we have really been thinking about, because we are targeting some of older population as well who have less access or less savvy, let's say, with technology, is to be able to work with them to be able to access the monthly surveys. So we are partnered with Dementia UK and Parkinson's UK, and are working with the Mental Health Trust, really trying to think about that. And I think one of the things we're going to be hoping to do is to develop a sort of PPI, a patient involvement, to be able to think about some of those barriers to make sure we're not missing out on some of those patients.
It sounds good. This is a problem though. I think we've had problems accessing, the language is a problem, and literacy is a problem, and access to, smartphones is a problem. And those are all the people whose voices aren't heard. Obviously, if it only is advertised on phones and things, then they're the people they don't even know about the survey. So it's a problem.
It is, yeah, it is a challenge. It's a challenge to reach them as well, to even let them know about the study, to be able to say this study we could do it in another way. We're happy to be flexible, to ask them the questions on the phone even, and not to be able to do the daily polls, because the monthly survey is providing a lot of information as well. So that's really trying to think. We are really trying to think about, given the restrictions around COVID, that you can't just sort of go to a community centre, which is what I've done previously, and gone and met with communities and talked about the study and recruited people directly there. How do we do that within COVID, and then also have a study that works for COVID by it being on a phone? So it's a really delicate balance.
Can I just ask a question of you, Zainab? It's John here. I don't know if you can hear me, but I was struck by this sense of helplessness and the emotional impact that shielding had on you. And I guess I'm asking the question because we know as a society that psychological services, and Kofi knows this as well, we're not blessed with loads and loads and loads of services. So I guess my question is, were you able to access support services around that space, because I'm thinking if an individual like you had experienced those feelings of emotional, angst and so forth, if they didn't have access to psychological services, that would be an even more challenging issue. So did you have access to that type of service if you needed it? I'm not saying you don't have to give us the detail, but if you needed it, could you have accessed those services?
So I don't think so. From what I understand, so services such as like Mind and other like private kind of or charity kind of services, they had to stop running all their services they only ran their services for really people in like crisis and really severe need. So actually, even if you were on the waiting list, from what I understood, even if you're on the waiting list, they would say, we're really sorry, we just can't give you any service at the moment because of the current climate. My support network was mainly my family, but I think one of the biggest issues that I've recognised in hindsight is the workplace, and that actually the workplace didn't really give a lot of their employees enough support in this area. I think partly they probably didn't know how to approach it. They probably didn't know the data as well. They probably didn't know how many people are actually shielding. So my organisation, for example, we were all working from home. So it's not very obvious whether you were shielding or not, because everyone was in the same boat. But I do think as we kind of start to go back to work, that's something that we probably will have to start thinking about, and how do employers also support their employees. So I guess that's a really long answer to know.
No, that's a good, good and helpful answer. Thank you. Let's see if there's any other questions, because I can see there are a number of not only other clinicians, but support group representatives and other patients. So don't feel shy is what I want to say to you. So if you've got a question, either put your hand up or just type into the chat box, and we'll respond to it in the time we have. Was that you putting your hand up, Kofi?
Yes, I kind of had like, it's going to be a follow-up to your question, but I was actually thinking about patient empowerment. So in your presentation, which was a very powerful presentation anyway, it was a very clear journey in terms of going from before the pandemic with the shielding, and now that you're coming out of the shielding. And I was looking at it more also apart from, let's say, the day-to-day emotional challenges that you had, but in terms of more broadly how we can use experiences of people like yourselves in terms of empowerment, in terms of getting a patient voice. And I think that might actually feed into Anna's study with colleagues in saying that moving forward, how do we get more of the patient's voice in terms of COVID, in terms of other sickle-related issues?
And I'm not sure if you want to take that, but I completely agree. I think everything that Kofi said was completely right, and we do need to, I think there's the power of storytelling, isn't there? And there's loads of stories to say over the last couple of months. But yeah, I'll let you take that, Anna.
I completely agree. I think one of the things that we've tried to do in our other research and really in this study is to develop that patient voice and make sure that we're asking questions that not only that make sense, that are, timely, and that are really getting at what people are experiencing. And you can't do that without the patient voice. That's not my lived experience. And you need that lived experience within the study. And I think there's no other way to do it. And so that's what we're hoping to develop, really, sort of with this partnership here, and then trying to engage patient voices. I know Sati, she might be able to talk a little bit, but has really worked with our patients to make sure their voices are heard within our studies as well. And that's one of the things we're hoping to do with the daily polls, is that, I can think of a question, and as a team, we think of a question that might make sense. And a patient may say that has nothing to do with my daily life, and can give us that experience.
And I guess just to add on to that, sorry,
no,
John.
go ahead, Zainab. Go ahead.
just to add on to that is, I think people probably underestimate how different the experience was for maybe people with sickle cell, for example, and then on top of that, maybe they're from Black and ethnic minority background, and on top of that, maybe they're from a socially deprived background, etc., etc. And actually, so many people say that we're all in the same boat, but no, we're all weathering the same storm, but we're all in different boats. You're in your nice yacht and I'm in my little dinghy, and it's actually about how do we show that to people, and how do people really understand that even though we all went through a really difficult period, some people actually had it much harder than others.
No, I was agreeing with you. I think our responsibility as a Sickle Cell Society is to help you with that, because we're clear that for the reasons you've just described, Zainab, it's important for that voice to be heard. And as Kofi said, you illustrated that very clearly and effectively in your very transparent and honest presentation. And there'll be lots of people like you with sickle cell or out there, and we need those stories to be able to affect change. So certainly outside of this process, we'll be working with Matthew, Anna and the UCL team to try and get many of those voices participating in that piece of work. We've got a question through the chat box, and it's from Tinu. Hello, Tinu. Glad you could join us. Tinu's question is, and this might be for you, David, I think, and Kofi, but Tinu's question is, where do we stand with coming out of shielding for children going to school? So if you remember, David, we had this before, so there was a concern in the previous one at the height of lockdown from parents about school when it was going to reopen. So that's Tinu's question. Do you want to say anything about that, given that we are out of shielding, some people are returning to school and so forth?
Yes, but yeah, I think, as you say, the advice now is that children, certainly with sickle cell disease, don't need to shield, except for a very small number of children with severe problems who've got other problems or have had a lot, who are, in fact, amongst our patients, amongst the 500 or so children with sickle cell disease we see, I don't think we have any who we think should continue to shield. I think that's important, and it's not, staying away from school is not a good thing, definitely, and we know that people have suffered a lot, directly and indirectly, during the time they've been away from school. For the things we mentioned, that a lot don't have good access to IT and haven't been able to benefit from any sort of distance learning that's available. So the cost of staying away from school is quite considerable, and the risk of going back to school seems to be very small. One of the things that has emerged over the the COVID pandemic and the huge amount of information that's been gathered is that children, young people, teenagers, young adults really are a very low risk of having complications of COVID, and that is true whether you have sickle cell disease or not, and that age is one of the main factors that determines risk, really. So if you're young, like children are by definition, then there's no real risk to them. You can be unlucky, but and I don't know the relative risk, but going to school, the danger of possibly being in a car accident or falling over on the way there more than the risk of getting COVID and becoming seriously ill because of that. And I think we saw a lot of parents who were saying, oh, they don't want their child to go back to school, and they were anxious about it and they're worried about it. But in fact, I've seen quite a lot of parents and children in the last few weeks, and all of them have sent their children back to school, and all the parents are so happy their children are now at school and they don't have to try and homeschool them. So I think I feel, there's quite a lot of information and quite a lot of opinion, and all the information suggests that children really are not, and young adults, you have to be pretty old to have problems with COVID, even if you have sickle cell. So the risks are very small, and the benefits of going back to school, which I think Kofi probably can talk about better than me, are enormous. So I think it's really important to go back to school.
Thank you, Dave. Yes, go ahead, Kofi. Go ahead. Yes, please.
A little bit to that, and I agree with David entirely, but also I think just to emphasize the point that a lot of the initial anxieties and the fear that parents had about children going back to school, that certainly has been allayed in the sort of families that we've seen sort of in the last couple of weeks or so. And the other point was that I also felt, so just when shielding was paused at the beginning of August, I felt that especially those children that kind of needed extra support in schools, whether they had an education and healthcare plan or just some sort of category by which they needed extra support, they were the ones who actually suffered the most in terms of not getting much from, you know, online to schooling or whatever, and in some cases actually not being able to utilize the technology or not being able to have it at all from that point of view. So it was quite important that, you know, we try to emphasize if they were not in that very high risk category, they had to actually try and get back to school. And in a lot of cases, we try to work with the teachers as well as the parents themselves in making sure that, you know, their fears and anxieties were kind of sort of taken into account, but making sure that they did get back to their normal education.
Thank you, Kofi. And just to give you some feedback via chat box, Tinu says thank you both very much for the helpful explanation. So listen, we started late, and that's why I've just allowed it to run over slightly. So I think we can take a couple of final questions. So I'm just checking with all of you who are being shy out there, because I can see there are a number of patients out there from different parts of the country as well. So any final questions, either in the chat box or raise your hand. Do I take that as a no? Okay, well, if there isn't any, I can't see any hands up, Matthew, or the chat box going. I can see some people smiling as though they want to ask a question, but don't want to. There's nothing like a wrong question or a bad question, by the way. Any final questions? Let me just check. Was that Nkechi? Was that you wanting to ask a question?
No, not the question, just a comment to say
Okay,
that the
Nkechi.
platform. Can you hear me?
Yes, we can.
No, not a comment, just to say that all around the country, the specialist nurses, speaking as a specialist nurse or community matron for South East London, and STAMMAP, we are trying to work to go back to pre-COVID by supporting our clients and making sure the screening program is running well in spite of all the complications of people staying away from hospitals and things. Maternity is now returning to their booking timeline of trying to book the women before by 10 weeks at least, to get them into the system to allow us to offer them prenatal diagnoses in a timely manner. So we are doing some recovery work, not just in South East London, but it's all across the board to ensure that we go back to our pre-COVID state. Thank you.
Thank you, Nkechi. That's very welcome, and that's why we had a nursing perspective from Keisha earlier on, which I don't know if you heard, but it's business. Keisha's words were business as usual, and trying to get back. So not just at Queen's, as you quite rightly say, in other parts of the country. So thank you and the specialist nurses for your contribution. I think it's 10 past or just about 10 past, and we did start 10 minutes late, so I was in the chair just being a little flexible with the time. So if there are no final questions, so nothing in the chat box and no hands up, can I first of all thank all of the speakers, and I don't want to pick anybody out, but Zainab, thank you very much, because it was a powerful, you know, a story from start to finish. That's not that the other presentations weren't very good, they were, but actually it's back to the point about the patient voice and the patient experience and the learning and understanding of what that means in a wider sense. So I thank all the panel for their contribution. Thank everybody who has logged on, even though some of you are very shy in asking questions today. I can just say, be safe, be cautious, the virus is still out there, and thank you all very much and have a good weekend.
Thank you very much.
Yeah,
Thanks for letting us take
thank
part.
you.
Really enjoyed it.
Thank you.
And thanks,
Thank
Zainab.
you.
Everybody was great, and Zainab, you were wonderful. Thank you very much.
Oh, thank you. Thanks, everyone.
Take care.
Take care now.
Bye.
All the best.
I'm
Bye.
waving, but from the back end of my camera.
Okay.